ahead and click record. There we go. Well, welcome everybody. Happy Tuesday and good afternoon. Uh, Welcome to today's Hope Cultural Training session. We will be hearing from Dr. Mary Isaacson on Native American cancer disparities momentarily. But before we get started with that, we are going to work through a couple housekeeping items. I just want to confirm that everybody is seeing my screen and the slides rotating through. Are you all seeing it okay?
Catherine, I think it's still on continuing education on my end.
Okay, let me reshare the screen. Thank you so much. So, bear with me. Technology, we've been doing it for about 5 years here, but still takes an effort every time we do it. All right, let's see here. Go ahead and present this slide. Okay. There we go. All right. Well, again, welcome everybody and happy afternoon. Today's session of our Hope Cultural Training series is featuring Dr. Mary Isaacson, who will be speaking about Native American cancer disparities. On our screen here today, you can see, let me just keep advancing forward. I'm not sure why it's frozen. Perhaps, Cynthia, would you be able to share the slide? I don't know why it's stuck for me.
Sure.
Oh, there it goes as I speak. But on your screen, we have a couple housekeeping items that I want to talk through. We are offering continuing education for today's session, and you can see our learning objectives available as the slides continue to advance. The Hope Cultural Training series is supported by our PCORI Engagement Award, so we are offering this acknowledgement and disclaimer about this award. Today's session will also be recorded and available later on our Growing Garden resource page. Our Growing Garden resource page will continue to be updated as we offer these sessions with not only recordings from each month's session, but also reference materials and resources that are shared by our speakers and in dialogue as we continue to move throughout the year for this series. Today's session is our second one in this series, and we're really excited to hear from Dr. Isaacson. But before we introduce her, I do want to invite Laura Fisher to share a opening reflection. Is Laura on the call with us today?
I am sorry. Have a cold, so I need to drink water really quick.
Oh, that's okay. Thank you, Laura, for being here.
So this morning, the reflection is kind of simple, but it's just relating it back to our medicine wheel teachings. And in Anishinaabe way, we always say that everything is cyclic instead of linear. So everything has a relationship with something else. And there's interconnectedness through all things, and that is reflected in relationships to nature. It's reflected in relationships to our community, and it's also reflected in ourselves as in our physical body. So our mental, emotional, spiritual, and physical, and everything. When you're out of balance in one area, that could be shown as an impact in another area within yourself. So if you're spiritually unbalanced, it could have a physical ailment that arrives. Or if you're emotional, like if you're grieving, that could also show in another aspect, physically, spiritually, or spiritually. And it's just the importance of the interconnectedness. So we don't ever look in things in a linear, like point A to point B, but it's how everything is interconnected and how everything is vital in your physical well-being, your mental well-being, spiritual well-being, but also in your relationships with your external world and nature. That is the teaching of the day.
Thank you, Laura. That's so timely. I really appreciate you sharing that with our group today and for allowing us that time to pause and reflect. I think I needed it with my own tech challenges and feeling that one. So very timely and appreciate that. All right. Well, without further ado, I would like to formally welcome and introduce Dr. Mary Isaacson. I'm going to go ahead and read her bio because she brings with her a wealth of knowledge and experience that is so important and relevant to today's conversation. So bear with me while I read directly from it. Dr. Isaacson is an associate professor and Christine Hyde Sorensen Endowed Professor in Nursing at the University of Nebraska Medical Center College of Nursing and is certified in hospice and palliative nursing and rural health nursing. Dr. Isaacson's NIH-funded program of research centers on addressing health inequities through the development of cultural responsive palliative care and cultural-centric palliative care messaging in partnership with American Indian tribal communities in the Great Plains. Dr. Isaacson is nationally recognized for her transcultural health disparity work and serves as a consultant for researchers working collaboratively with tribal communities. Dr. Isaacson is highly skilled in Indigenous and qualitative methodologies and is the co-author of The Comfort with Communication in Palliative and End of Life, CCOPE for short, which is a validated instrument to measure healthcare clinician comfort with palliative and end-of-life communication. Dr. Isaacson serves as a board member at large for the Rural Nurses Organization, secretary for the Council of Public Health Nurse Organizations, and chairs the Hospice and Palliative Nurses Association's Fellow in Palliative Care Nursing Committee. In recognition of her accomplishments in research, Dr. Isaacson was named the recipient of the 2024 F.O. Butler Award for Excellence in Research, Scholarship, and Creative Activity. I'm so excited to welcome Mary to share with you today, and I would be remiss if I also didn't recognize that Mary is a member of our HOPE leadership team who has helped to support the development of this series and our ongoing work as part of the HOPE Collaborative. So welcome, Mary. I will stop sharing my screen and turn it over to you.
That sounds good. That'll give me time to get this set up as I lose everybody. Okay. I just want to make sure that you guys can all see my screen.
Yes, I can see it.
Yes.
Wonderful. Okay. I don't know what it is about becoming nervous before you do this, but Ampetawashte, which is good day in Lakota, and it is morning yet for me and afternoon, I know, for many of you who are on this presentation. It is my pleasure to provide an overview of Native American cancer disparities in Michigan for today's session. Let me get my cursor in the right spot here. These are the learning objectives, and you can see that many of them align already with the HOPE training and objectives. So we're first going to take kind of a big picture approach, then we'll bring it down to understand better what disparities we see in the state of Michigan, and then we'll take a dive into the or deeper exploration of the social and structural determinants of health that can contribute to these cancer disparities. And finally, we will and on a positive note, thinking about what is it that we can do to help to make things better or try to improve quality of life. And I have no conflicts of interest. However, I do wish to disclose that the lens that I share this information with you comes from what I have learned in my relationships with South Dakota tribal nations. So I'll begin this discussion just bringing to the forefront the abominable cancer statistics for our American Indian and Alaska Native populations in the United States, and then specifically for Michigan. While this data can be distressing, it is my intent to lay the foundation for thinking beyond the numbers, to really remembering that these numbers represent people and families. This foundation provides us with a launch point to understand reasons for why they exist, and then to reach beyond the numbers and imagining how do we, as a community of two-leggeds who have been blessed to share Mother Earth, can work together to resolve these disparities. So according to the Office of Minority Health, American Indian and Alaska Native adults' cancer rates are lower than non-Hispanic whites, but disparities are present in certain types of cancer. And on this slide, I've tried to divide it out into males and females to kind of give you a clear picture that it is not equal. American Indian and Alaska Native males were more than twice as likely to have liver and intrahepatic bile duct cancer than non-Hispanic white males, and are also almost twice as likely to have and more than twice as likely to die from stomach cancer than non-Hispanic white males. They also have a greater incidence of colorectal cancer, about 1.3 times higher, esophageal, kidney, and lung is actually reducing compared to non-Hispanic whites. So that's interesting, yet lung cancer remains a challenge. Now, on the female perspective, American Indian and Alaska Native females were 2.7 times more likely to have and 2.3 times as likely to die from liver and intrahepatic bile duct cancer than non-Hispanic white females. In addition, they were more than twice as likely to have and nearly 3 times as likely to die from stomach cancer than non-Hispanic white females. They also have a 1.3 times higher rate of cervical cancer, 1.4 times higher rate of colorectal cancer, 1.7 times higher rate of kidney cancer, and breast and uterine are very similar to what is seen in the non-Hispanic white population. So let's think about now the 5-year survival rates. Because you're diagnosed with cancer, you could hear that the mortality rates are significantly higher. But what I would like you to think about is, so for American Indians and Alaska Native males and for non-Hispanic whites, across the sites, meaning the cancer sites that were noted in the earlier ones, American Indians and Alaska Natives 5-year cancer survival rates were far worse across all categories, with colon and kidney cancer being nearly the same. And that is also true for American Indian and Alaska Native women, with the exception of cervical cancer, where American Indian and Alaska Native women have a higher survival rate. So that is something to aspire to and to really think about. However, now let's look at mortality rates. The most recent data is from 2018 to 2022, and this is where the numbers become very troubling. So for American Indian Alaska Native males, the non-Hispanic white ratio they have a 1.4 times likelihood of dying, liver 2 times, prostate, and you can see lung and pancreas have started to decrease a bit. And for women, just as I said, there's a 5-year survival rate for cervical cancer is better in women. And that data was from 2014 to 2020 that I shared. And this more recent data of 2018 to 2022 look at the cervical cancer rates. So just curious for those that are on this call, any ideas for the changes in survival to mortality? So you're diagnosed, you survive this cancer diagnosis, yet in the end end up succumbing more frequently than a non-Hispanic. Any ideas? Anybody want to put anything in the chat? Although I know I can't see the chat, so somebody will have to tell me what comes, or you can take yourself off mute. Oh, there we go. No takers. Okay. I'm going to get into my,
Follow-up care, late diagnosis,
yeah,
treatment trajectory. Those are all in the chat. Quality and access to care, long distance to follow-up appointments.
perfect. Thank you, Cindy, for reading that for me. I appreciate it. Too many buttons to push here. And you're
No worries.
exactly spot on for all of you. And we'll talk about that even more in just a little bit. So to help us better conceptualize this data, it can be helpful to determine, is there a particular catchment area where the rates are highest? To do this, I often find it helpful to consider American Indian and Alaska Native health from within the Indian Health Service regions pictured here. However, this does not really tell us where the greatest number of American Indians and Alaska Natives live, because as we remember, we had forced removal and relocation and the development of reservations. And there are many individuals who live in urban Indian community or in the urban regions. What this figure does show are the 12 IHS regions, which include tribal nations. And it also shows the top 10 states where the greatest percentage of American Indians and Alaska Natives reside. We also need to remember that this data is skewed, as American Indians and Alaska Natives are often misrepresented in the census data. However, in 2023, the 10 states with the largest percentage of American Indian and Alaska Native populations were Alaska, New Mexico, Oklahoma, South Dakota, Montana, North Dakota, Arizona, Wyoming, Washington, and Oregon. And as of 2024, there were 574 federally recognized tribes and a number of tribes recognized at the individual state level. There are also many tribes that are not state or federally recognized. And without that recognition, there's a very grave disparity because there is no funding. So by this data, the greatest concentration of American Indian persons are Alaska, and then we talk about the Southwest, which will include Arizona, New Mexico, parts of California, Colorado, Nevada, Oklahoma, Texas, and Utah. The Northern Plains, which are considered Montana, Wyoming, North Dakota, South Dakota, Nebraska, and then the Pacific Northwest. And as you can see, the purple area and actually the Bemidji area don't necessarily include high numbers of Native American persons. So in an article published in 2019 by Melkonian and colleagues, they featured cancer registry data and CDC data and SEER, which is surveillance epidemiological and results data from the National Cancer Institute, whose purpose was to provide a comprehensive update of cancer incidence rates in the non-Hispanic American Indian Alaska Native population in 6 geographic regions in the United States. They also evaluated long-term trends in cancer incidence from 1999. So again, notice how old this data can be, to 2015 for the top 15 cancers.
I'll plug her into my ears. So listen.
So what's critical to understand when you're looking at data like this is recognize that we had IHS service regions, which are kind of represented in here, but it's very critical to really look at how are they talking about the data in this picture and what does that represent and what states are included. So let's see, they avoided the long-term trends, and then to avoid undercounting, the investigators restricted their analysis purchase referred care delivery areas. And you can see that's by county in the blue. And purchase referred care is what Indian Health Service will do because they have limited resources to be able to provide sometimes higher end x-rays, surgical care, oncology care, etc. And so that care needs to be referred out. And is this an easy process for an individual who needs to have further treatment for a cancer diagnosis? Absolutely not. Are there delays in care related to this? Absolutely. So something to remember. Their work also from the older data showed that nationwide, across all regions, American Indian and Alaska Native men have significantly higher rates for lung, colon, kidney, liver, stomach, and myeloma. And colon cancer was actually higher in 4 of the 6 regions except the East and the Southwest. Kidney cancer was higher in 4 of 6 except for Alaska and the East. And liver and stomach cancer were higher across all regions. For women, kidney cancer was higher in all regions except the East and the Southwest. Cervical cancer was higher in all regions, and it was statistically significant in the Northern Plains, Alaska, Southern Plains, and the Pacific Coast. Liver cancer was also higher across all regions. So now what I'd like to do is really explore lung cancer specifically in the US. So according to statistics from the American Cancer Society, and which I want you to look at on this slide is where those red arrows are, because that indicates the American Indian Alaska Native population. Lung cancer incidence rates are highest among Black women, whereas mortality is highest among both Black and American Indian and Alaska Native men. American Indian men and women have had the highest smoking prevalence by far since at least the early 1990s, when the data first became available. And in some regions, including the East and the Northern Plains and Pacific Coast, lung cancer incidence among American Indian and Alaska Native women is similar to or higher than among their male counterparts. American Indian and Alaska Native women have the highest mortality of any racial or ethnic group, and a 10% higher than white women, who rank second. So let's think about socioeconomic status. And what I love about this slide, although very, very busy, it kind of differentiates all of the different counties. And you can see death by per 100,000, the darker blue is obviously not, is the worst areas. So the risk of lung cancer is greater in persons with lower socioeconomic status. For example, lung cancer death rates in individuals 25 to 74 with less than 12 years of education are nearly 5 times higher in men and 4 times higher in women compared to those with over 16 years of education. This disparity reflects historical differences in smoking prevalence that remain today. And in 2021, for example, 21% of individuals without a high school diploma and 31% of individuals with a GED smoke cigarettes compared to 3% of individuals with a graduate degree. Persons with low socioeconomic status were more likely to be diagnosed with advanced stage disease and lack access to high quality cancer care. So look at the state of Michigan and think about the catchment areas and think about the death rates. And I sound like Miss Gloom and Doom here, and I apologize, but this is our reality check right now. So these statistics are overwhelming and distressing. And a reminder that the previous statistics were nationally. And what we're now going to do is review Michiganders, which I learned is a word, cancer burden. On a side note, the data that I'm sharing with you here is from the Michigan Department of Health and Human Services 2020 Cancer in Michigan report. I was unable to locate any report that is specifically dedicated to American Indians whose home is in Michigan. I found this interesting as my home state of South Dakota actually has a report specific to South Dakota American Indians. I am not sure if this is really related to the differences in population. For example, of the 900,000 individuals who live in the state of South Dakota, 9% report American Indian as their race. And in Michigan, of the 10 million, that number is 0.8%. I don't know if that is, but that is a question that raises in my mind. But I wanted you to be aware that this in itself is a disparity. In addition, as I was exploring behavioral risk data, the tables that were specific to race and ethnicity are listed as such: white, non-Hispanic, Black, non-Hispanic, other, multiracial, non-Hispanic, and Hispanic. Again, making it very challenging to provide more detailed information and also for communities to assess current and past trends. Now, these statistics are very troubling once again. You consider the population of the state, which is 79% white, Blacks are 14%, Asian 3%, Hispanic 6%, and American Indian 0.8%. So the population, notice where the red arrows are, that is the lowest at 0.8%, has the third highest incidence and mortality rates in the state. How does this then translate when we look at a map of Michigan? And a disclaimer, these are all approximations where I put these dots, but I'm trying to land roughly where the 12 federated tribes lands reside. So if I'm off, I apologize in advance, my mistake. So they are approximations of where I believe the Michigan's federally recognized tribes are located. Once again, you can see that they are often in the 40th to 80th percentile, which is incidence on the left. But even when the incidence is lower, the mortality, which is on the right, is often in the 40th to the 79th percentile. This is once again for a population that comprises only 8.8% of the total population. This is alarming. The trends for American Indians in Michigan are distressing as well. However, there's encouragement in the mortality statistics. So in incidence, and again, from 2000 to 2017, so not current data, 18% increase among the American Indian population. But then when you look at the mortality, there is a 44% decrease. So that is an encouraging sign in itself. But now let's look at cancer cases and see what they are determined to be. So cancer cases are noted on the left, and this is specific for American Indians, and then the death rate is on the right. So for whites, lung bronchus was 27.4, and for blacks, for lung bronchus was 24.9%. And colorectal for whites was 8.2%, and blacks and Asians 10%. So not about comparable to those deaths as well. And now let's get into the specifics. So cervical cancer rates for American Indians, I don't have a slide on this one, were small enough in the state of Michigan that they could not be adjusted per 100,000. And what was really exciting about those statistics, though, was that the stage of diagnosis where American Indian women was that they were diagnosed at higher rates of being in situ, or at 88% compared to other ethnicities. These are the breast cancer rates, and they are 73.4 per 100,000 compared to 124 and 123 for whites and blacks, respectively. So that is a positive sign. And then the mortality rates are also lower. The next slide is for colorectal cancers. And American Indian is right up there with in the higher rankings. And again, remember the population density of our American Indian population in Michigan compared to the greater whole. So again, a concerning slide. However, there is a glowing concern also for lung cancer rates. And this is what it is in Michigan, 100.9. And then the mortality rate is also much, much higher. So again, as we think about this, in some of the areas, cancer rates are less, and they're similar to Black and whites in the state of Michigan. But again, the percentage density is also less. So those rates in themselves are alarming. So now the big question, why are there so many disparities? So again, if you'd like to put in the chat, what are your thoughts? Why are there disparities? You already raised some of them when we talked earlier. What's a common one? And you can take yourself off mute if you're not shy.
Mary, I'm reading in the chat responses, including distrust of the system, stress, unable to get access due to inaccurate numbers.
Okay, good. Anybody else?
Oh,
Okay,
environmental toxicity has been added.
that's a good one, a very good one. So here are the cancer disparities that I'd like to highlight that also align with what many of you have noted here. And these come from the American Cancer Society and the National Cancer Institute. And the first big picture item to think about is race and ethnicity are automatically a disparity. So the color of your skin matters, which is sad, but unfortunate. And that is the case here in the United States. Along with that is sexual orientation and gender identity automatically increases your disparity for cancer risk and cancer care. Along with that can be socioeconomic status. And this, as we talked about earlier, can be linked to educational attainment. And that can lead to low health literacy. In the work that I have conducted in our tribal populations in South Dakota, there is grave poverty in our reservation communities, and many still do not graduate from high school. And we'll talk a little bit more about that when we get into some of these other disparity or areas that could be links to disparities. So there might be a lack of understanding for the need for prevention and screening. In addition, when diagnosed, it is important to ascertain with the American Indian person what questions they may have and wait for them to feel comfortable to ask. What I have learned in my work with our American Indian population in South Dakota is that they listen intently, and they also often feel that if the healthcare clinician that the healthcare clinician will tell them everything that they need to know. However, the healthcare clinician often sees that this lack of asking questions is either a disinterest in their care or they're understanding everything. So you can see here's a big gap already in that, because in the work that we had done on a study, we interviewed individuals, our American Indians with advanced cancer, and then we also interviewed healthcare clinicians. And this was the disjointed or the two disparate views that we had. Along with this is geography. The earlier map showed roughly about where the tribal communities reside in Michigan. What is access like to health care there for primary care? What is access to specialty services like oncology care or palliative care? How far do they need to travel for treatments? And we've heard individuals saying in this slide, geographic distances are an issue. Do they need a treatment every single day? Will they need to stay? Who will help pay? Is there a reliable vehicle and money for gas? So questions to always ask yourself when your patient comes in who is of American Indian background and resides in our reservation communities. Social determinants of health. And this is a big category, as we know. And they are currently defined as the conditions in the environments where we are born, we live, we learn, we play, we worship, and age that affect health and quality of life. And as you can see, this category is huge and actually encompasses much of what we have discussed already. However, let's really talk about the elephant in the room, racism. It can be internalized, interpersonal, institutional, and structural. An example of internalized racism are what we call those implicit or explicit, or I should say, and explicit biases. Implicit biases are something that all of us have. It doesn't make us bad people. It just comes from the environments in which we were raised. And it is something that we have to, as I always tell students, you have to check at the door. And you need to think, okay, I'm greeting this person, I'm meeting them for the first time. What do I know? And what do I think I know? And then go in with an open mind. And those explicit biases are the ones, I know this person and I know they come from this family and this is what I know I'm going to expect in my interaction. Those are explicit biases. Interpersonal is when we engage with others and how our beliefs may actually impact that interaction. And so that's kind of that combination of those implicit biases where they're a part of you, you aren't necessarily aware that they're happening, and it might be in something that you say that you didn't even recognize was a bias. So again, recognizing our own lack of understanding is critical oftentimes. Institutional, this is really about what happens in our institutions like healthcare agencies and schools. And in this, I'd like really for people to think about our staff trained in cultural humility and also to engage respectfully and thoughtfully with cultures with whom they care for or teach. So something to think about. And in work with our tribal populations in South Dakota, that's what we hear over and over again, is that the people that they go to seek care from don't understand, and oftentimes they feel judged for who they are. And then finally, we have structural racism. These are the cumulative effects of the history, the culture, the ideologies, and the interactions of institutions and policies that systematically privilege one population over another. Racism in all its forms has much to do with where people live, learn, play, and worship, and directly impacts health and quality of life, which then leads to the structural determinants of health, which are the broader social, economic, and political factors that influence the health and well-being of individuals and populations. In South Dakota, we have 9 American Indian reservations with some of the most appalling poverty and healthcare statistics in the country. How might structural determinants of health be determining these conditions? And let's also talk about Indian Health Service and how it's funded. For those of you who are unaware, Indian Health Service is funded through the Appropriations Committee through Congress. However, it is often one of the last agencies that is funded. And I've often been told it's really whatever money is left over is given when everything else is funded is what's given to Indian Health Service. So what does this mean? They are severely underfunded. And I think that is a component that many individuals do not understand. They just think, well, you get money from Congress, you have the ability to care. No, it is severely underfunded. Then need to think about how are they staffed? Are there consistent clinicians where relationships are built and there is a continuity of care? What about our Indian Health Service pharmacies? Is their formulary the same as what is available at Walgreens or CVS? Why? or why not? And how does that impact care? In the work that we were doing with our oncology providers, they said that's one of the most challenging things. They'll order a medication for a patient who resides in a reservation community. They go to the formulary, they don't have it. So there's this constant, then you got to order something different. So there's a delay in care again. A component of Indian Health Service that you also need to be aware of is a term that they call 638. And that is where the tribal community will, or leadership will say, you know what, we can provide our care and better than what Indian Health Service is doing. So we are going to take that money, and we, as our tribal government, are going to manage the health care of our communities. And my understanding is that is how the care is in Michigan. That is not the way things are in South Dakota. Some of them are transitioning to that. So that is one very, very positive component. But does it mean that these communities that have done a 638 are any better funded than those out of IHS? Absolutely not. So again, always working with limited funding. And finally, where does colonialism, genocide, and historical trauma factor in? For the purposes of our discussion, I'd like you to keep those terms in mind, and they will be covered in next month's presentation. They are critical to our understanding and very difficult to grapple with. So what can we do? That's some pretty tough stuff. And after reviewing this heavy content, it can be really easy for a person just to get dismayed and to think, well, what's the point? How can we even begin to address what is happening? As a nurse educator in my work with students, I always let them know that it is important to really understand these statistics. You can't go in there blind. You have to know this is what the reality is, but you have to look for those pockets of hope and what is going well and where are the strengths within the community, and begin centering your focus there. How can you develop trusting relationships with communities and work in collaboration with them to help them to address these inequities? And that is critical. We can't go in as the savior. We can go in as a collaborator. And I often say I'm a cheerleader. What can I do to help and put my strengths to work to help the community? So to end, Han and colleagues had a systematic review that was to examine facilitators and enablers of cancer screening services in Indigenous communities. And these are some of the things that they found. And I'd like you to think about your own communities and the own work that you see happening. Culturally tailored was one of the big ones. And this is to address the potential lack of awareness about the need for cancer prevention services. It was really identified that there needs to be a culturally respectful approach to the information disseminated, and an integration of the language and artwork would also be appropriate. There should be a combination of oral and visual, and most importantly, to include and engage the community in the development and the delivery of services. Community involvement is critical, and discussions need to be delivered by a trusted member of the community, such as a community role model who can be a formal patient navigator to guide individuals through the process. Sometimes attending cancer screening sessions as a group and forming partnerships with trusted organizations within the community can help lead to better cancer screening. Relationships was seen as a major facilitator of those screenings, but there are many negative experiences from the past that have led to the current mistrust. So how can relationships be rebuilt? You have to rebuild the relationship first before you can launch a screening effort. And then empowerment, involvement of the person to be screened in the decision-making process. For example, there was one study they talked about in cervical screening, or I should say in many of the articles, where they indicated a preference was to administer the test themselves. providing information and allowing time for questions, and then restating it and follow up. Don't just leave it, but then follow up to see what else is going on. And you'll notice also within there about inclusion of family and community. A family is who the patient says they are. And in our tribal communities in South Dakota, my goodness, it's that community, it's the role of the community to heal. And the community, they need that community in order to heal and to feel the power of healing. And it can't be a one size fits all approach. We have to address power imbalances so that, and recognizing that when somebody comes to you in a screening event, you're already at a power imbalance. So how do you level that field? And these are my references. Are there any questions for me?
Thank you so much, Mary. I think some folks will probably be posting questions in the chat, but would welcome anyone to come off mute and share their video if you'd like to ask Mary some questions. In the meantime, I do just want to thank you so much for sharing this information. It's so important to have an understanding of all of this background history, the impact of cancer disparities across these communities as we continue to embark on our study and our dialogue as part of this Hope Cultural Training session, or I'm sorry, series.
Somebody said, highly recommend viewing the series Yellowstone from the perspective of Montana's indigenous population, lack of resources. So perfect, absolutely perfect. You know, as I'm waiting for questions, hopefully somebody will be brave enough and interrupt me if you wish. I think of one of the studies that when I first went out to our tribal communities well, it wasn't the first time I was out there, but was in the role of understanding hospice and palliative care from their perspective. When I went out there, it was really to see, is hospice and palliative care culturally responsive or culturally congruent with our tribal life ways? And what I really found that was interesting is that yes, it was. So that was interesting in and of itself. And I thought, oh, sure, we now need to get palliative and hospice care up and going. That wasn't their priority. Their priority was to understand living wills, last wills, and advanced care planning. And what we did was actually wrote for a larger grant within our South Dakota Comprehensive Cancer Control Plan. And I worked with 3 elders, and we took an advanced care planning guide that had been developed by the State Department of Health. And we incorporated Native artwork, Native language, and they rewrote it in terminology that was familiar to them. And then 2 of the elders went to the 9 different districts across the reservation and delivered this training on a one-to-one level. So in a month's time, they traveled over 1,000 miles and met with over 200 people to talk about it. Now, in that role, I handled the money. I helped to get the graphic design done, but we organized the artist and everything together. But essentially, I made sure they were fed during all of our meals. And it was just beautiful because we need to take a step back often. So I see that somebody has come off, shown a face. Does that mean that you're going to speak? Yes.
I would like to ask a question. I don't know who you were speaking to. My name is Rachel Gross, and I'm so thankful for this series. I think maybe I don't know if this is appropriate, but when you say that culturally tailored information dissemination, is that when I lost a little bit of that because my microphone went out, but can you speak more to about what that means?
Absolutely. So, and that was kind of the example I was just giving, is that the information that you're giving, that it actually represents the culture and the cultural views so that the individuals can see themselves in this work. We often think that all we have to do is, okay, so this has been working really, really well in Omaha, Nebraska. All I have to do is take it and, do the same thing. That's not going to work. And you need to show why is this important and work with those individuals who are key leaders in the community and trusted leaders in the community, and then tailor it to each of the community's needs. So, and we were actually thinking, we're working with 3 tribal communities right now, and we thought we would have to deliver. We developed a palliative care message, and we thought we would have to develop 3 different palliative care messages. But we have a community advisory board that consists of members from all 3 communities. And when we showed them this first one, they said, no, this works, because they all have the same language and, similarities, but each reservation has different resources. So again, knowing your community, trusting your community to lead you, I think is probably the biggest thing. And then incorporating their views into the work you do. Great question. Thank you. So.
I see Mara, you have your hand up. Go ahead. Oh, Mara, you may still be muted, it looks like.
Can you hear me now? Yeah. It's sort of a question and a comment. So when I did my first postdoc, I was on the Thai-Burmese border working with migrant and refugee populations. And I became familiar with 3 M's, they called it: misfits, medics, and missionaries. And there seemed to be certain types of populations that were drawn to some of these vulnerable populations. And I remember this sort of transitory nature of there was just like this constant turnover of staff, and there were kind of the more regulars. But could you sort of comment to the potential risk, I guess, of the transitory nature of the working relationships that evolve, the trust building, and like what some of these communities may have experienced over time?
Wow, that's a loaded one. You're absolutely right. And when I started my PhD and wanted to work with our tribal communities, my minor advisor, who was advising that component of it, said, I will help you, but you must promise never to stop, because they have experienced enough helicopter research and enough helicopter support where you drop in, you drop out, you get what you need, and you're gone. And so it is true, and that has happened, and that is why there is so much mistrust. Or I even see it today where people don't realize, well, I'm just going to interview a few people here in this community, in this tribal community. I don't need to get their approval. Yes, you do. You don't understand. They are sovereign nations. They are in charge of everything that goes on there. And so that creates barriers for all of us. I believe, I would love to say that it's a lack of understanding, but I would also believe that it is it's where many of us feel like, well, I'm here, I have so much to offer. They'll just, they'll want me. And I think it's a complete lack of misunderstanding of what the needs are. And I know that within the work I do with students and those that I work with in our tribal communities, if they're coming with me, this is the education and the cultural training you have before you even start. And that's missing. And we also know in our high schools and our educational systems, there is no education, or very limited education on what really happened. We had an anti-racism grant, try and get one of those now, sorry, from the Hillman Foundation, and I was working with the urban Indian population, and we developed a Being a Good Relative curriculum for our undergrad nursing students, and they received 4 modules of cultural education, and then also worked with our tribal Native American Nursing Education Center. And then we were working within the community. And the thing we heard over and over again is, why did I not know this? And this is in the state of South Dakota. Why don't I understand the boarding schools, et cetera? And then that whole mission role of, I never say I go on a mission trip. I cannot stand that word because it has those negative connotations. I'm here and I'm here to visit and I'm here to learn and to be open. So I know I didn't really answer your question because I think it's such a broader, deeper there's so much misinformation out there and people don't understand. And Laura, I see nodding her head. She probably can add a lot to that.
But the piece about the consent, I think, is huge. Yeah, which is like the empowerment piece,
Absolutely.
and then
Absolutely.
being able to say no.
Yep. And then you go back for continuing review. Right now we're all done with our research, but we're writing the manuscripts. So I have to have continuing review because I still have the data. And then before we publish, do our tribal communities review those publications? Absolutely. Does everybody do that? No. But should they? Yes. So then it takes time, but it's worth the time. So. Thank you for the question. It's a great one.
I think we have time for one more question if anyone has a question or a comment. All right. Well, Mary, thank you again so much for sharing and speaking on this topic today. Continue to look forward to building our understanding, listening, and gaining perspective through this series. And glad that you've been a part of this to help us kick it off. For those of you who are on the call as participants, want to thank you all for joining us today, for engaging in this dialogue, and for participating in our polls and checking in. I look forward to continue to hear from you, to understand your perspectives, and we'll see you again in April. In the meantime, please check back at our Growing Garden resource page. A link to that, as well as today's recording, will be available in a follow-up email to come. If you have any challenges with technology or connecting to this meeting, please don't hesitate to reach out to myself or Paige Ortiz, who is supporting this series from a tech perspective. So, and I guess with that, I'd also like to thank Dr. Cynthia Bell, Laura Fisher, and Beth Seeloff, who are also part of our amazing team, our Hope leadership team, as well as Dr. Frank Anamikwam and Don Lyons, who support that work as well. So I'm not sure if they were able to join today, but do want to recognize their contributions to this effort. So thank you all so much for joining today, and hope you have a wonderful afternoon. Thank you.
Thanks, everyone.